Thank you, sir, for that warm welcome. I think that's too much for introduction. Anyway, I'll be talking on on this complicated system, that's the vestibulo spinal system. I just happened to be on a trekking early this week, and then when we were going to this double-decker route bridge, and we had to cross this kind of a bridge, so everything was swaying. Then that was when you realize that how important is your balance system to keep you standing erect. So when as we go into this topic, I would just like to cover talk about a few important points here. One is that we all know how important it is in humans and in animals, how the proprioceptors from the limbs, from the legs, they help in recruiting the muscle response. And but this corresponding effect has not been well described in related to the vestibular inputs. And unlike the ocular reflexes, the spinal reflexes, they cannot be tested independently for the strength in the vestibular inputs. And again, unlike the ocular reflexes, the proprioceptive reflexes cannot be switched off, which means that if the proprioceptive from the ankle is deficient or deficit, it is taken over by the knee or the hip. And again, because of the difference in the site of origin of the vestibulospinal tract and the pathway along the brainstem, so you cannot quantify the response or the contribution of the vestibulospinal system with from the amplitude of the vestibulocular response. And again, the rate of compensation is again different. Coming slightly to the anatomical considerations, once we activate the labyrinth, they set sets of muscle response, and these are linked by different tracts, which include the vestibulospinal tract, the reticulospinal tract, and again from below upward is the spino-vestibular tract. The medial vestibulospinal tract, these are bilateral tracts. Okay, they run bilateral. Most of these fibers, they originate from the descending vestibular nuclei. That's the major component arises from the descending, with a slight contribution from the lateral nucleus and the medial vestibular nucleus. And towards the lower end of the medulla, these fiber they shift to the other side. Okay, they are contralateral fibers and they are ipsilateral fibers. And these fibers, the medial MSVT, most of the fibers they terminate in the cervical cord. But you have a part of it which travels downwards towards the towards the thoracic segment. They are generally what do they function? They generally bring the axial, that is the neck, and the trunk under the control of the labyrinth, but not the limbs. In contrast, that the lateral vestibulospinal tract, these are basically they carry the excitatory axons, and they are exclusively ipsilateral. And most of these fibers of the lateral vestibulospinal tract originates from the lateral nucleus, with a slight contribution coming from the descending vestibular nucleus. And these travel the entire length of the spinal column, and they not only bring the axial but also the proximal limbs under the control of the labyrinth. But it's not only that there's a connection between the vestibule and the spine through the vestibulospinal tract, but there are also alternative track from which the fibers or the signals go from the vestibular nuclei to the spine, that is through another pathway, that's the reticulospinal tract. These reticulospinal tract, they are bilateral tracts. They have, according to the site of origin, we have the medial reticulospinal tract and the lateral spinolateral tract. Now, that is what these are two tracks which carry signals from top to bottom, but again we have another set of signals. So when you have to maintain a balance, you have to take inputs from the visual inputs, the labyrinthine, the vestibular inputs, and also the proprioceptive inputs to maintain your balance. Now the proprioceptive inputs come from two ways from the spinal column. That is, one is the ipsilateral. We have two pathways, that's the ipsilateral and the contralateral. The ipsilateral, which is generally from the cervical dorsal root, and it travels upward and ends and supplies the gives a collateral to the unilateral descending, the medial vestibular nuclei on the way toward the cerebellum. And we have the other the contralateral. These rises from the entire length of the spinal level. Generally, the ipsilateral is mainly from the ipsilateral, that's from the neck. But you have the contralateral, which gives signals right from the lower part of the or an entire length of the spinal column, and they travel on the they give collaterals to the contralateral side of the lateral vestibular nuclei and the descending vestibular nuclei on the way towards the cerebellum. So that's about, in brief, about these connections. Let's see how would you like to assess balance control. You have two type of tasks which we perform on a day-to-day basis. These are generally the static balance control. Static balance control is when you're standing upright, maintaining your balance upright when the surface is firm. Now to do this, we have two methods, two techniques to measure. One is by using the force plate and the body mounted sensors. Now the force plate, they measure the force exerted at the feet on when you're standing on a firm surface. Now by estimating these forces, you can also estimate the sway of the center of mass when your surface is firm. Then you have the other way to assess is through the body mounted sensors. These body mounted sensors are more, they give more qualitative information about the balance during gait and stance. Like the force plate, they give more information about only in the stance. But when you do body mounted sensors, they give you more information also about your balance during gait. What is then we have another task, that is the dynamic postural control. Dynamic postural control is maintaining an upright balance when the surface in which standing is moving, or there is a perturbation of stance. Now the perturbation of stance can happen in two ways. It can be external force, where the surface on which standing is made to move, as you're doing in dynamic posturography, or else from an internal force. So internal force, when you're making an involuntary movement, or else you're making some anticipatory postural adjustment. So these this is the second type of a task. And how do you analyze these dynamic postural control? That is by the system called the dynamic postural system. Here there is a perturbation of your surface in one direction or the other, and it gives you the muscle response involved in the vestibular disorder. Now let's see what are the directional attributes, or rather the motor aspect of vestibular spinal system to balance, and these we will also apply it clinically. You see, whenever there's a vestibular loss, there's also a considerable amount of instability when the mass is moved in either direction, left to right or thing. So what we are talking about in vestibular spinal control is basically in these movements which we make. There's the pitch movement and the roll movement. So these are the two movements which we often perform. So we will see how the vestibular spinal tract they manage these or how they manage these two movements to stabilize the body. Now what is the pitch? So in the pitch is like now like when you stand in one position and your base is perturbed backward. So what is the reflex? What happens when it's perturbed backwards? Your knee tends to flex a bit, and then your body, your trunk, it flexes. So you maintain that balance. When you're thrown backward, you balance. But what happens when you have a vestibular loss? When you have a vestibular loss, when you perturb the limbs, for example, when you perturb the limb backward, you completely, there's an excessive backward movement. So there's excessive throw behind, and then there's a body, your body is thrown excessively forward, and there's a reflex action which happens, which tries to bring your body back, and again your body gets thrown backward, and you tend to have a backward fall. So why does this activity happen? Because when you are maintaining a balance when your body, when the surface perter backward, is that your the tibialis anterior and your say your quadriceps muscle, they go into contraction, which brings your legs to flexion. Okay, now when you have vestibular loss, now this action is decreased, so you tend to have more of extension, restriction of extension. And at the same time, when your body is thrown, your body should be pulled flex forward. So in vestibular loss, what happened? That flexion is increased. Okay, there's more of an increasing, or rather more of activity of the abdominal muscles, so you tend to flex more, and then the reflex action of the spinal muscles, it tend to extend, increase activity, and then you extend more. So there's a increase in rotation of the leg, increase forward pitching, and then with the reflex, increase extension, and you tend to fall. So this is what happened in a vestibular loss. Now what's the role? How does the role takes place, and how does the balance takes place here, and what happens in vestibular loss? Now we are taking a role. What happens normally? What normal is that suppose your surface is moved to the side. This is a role. Okay, so it's moved uphill. So what happened to maintain the posture? You tend to fall. You know. So what happened here? You tend to flex your uphill. So if you perturb this way, your left thigh, say example, this gets flexed to maintain, and this gets extended. So you maintain that stand, and then this pelvis drops back. Okay, it drops to the downhill because of the movement this way. This hip drops downhill, but at the same time your trunk, you try to maintain the balance, you tend to rotate uphill. So you maintain in this kind of position. So you maintain the center of mass in the center, and you become upright. You stay upright. Now what happens in a vestibular loss? In a vestibular loss, all these activities go haywire. You have less extension. You cannot flex this limb, and there's less extension of this. So what happened? This you cannot flex. You cannot maintain this balance, and then this downhill movement of the pelvis increases, and then the trunk which is supposed to be twisted and to maintain to oppose the downhill movement in the hip, your trunk should go uphill, but that reflex is also eliminated, and your body tends to rotate more towards downhill, and you tend to fall. So this is what happens in a motor aspect. So we see that it's shown that the central control for these responses, for both the roll and the pitch, they are organized separately in the central nervous system. Now that is the motor part, and let's see how the sensory part. Now suppose now the signals has to come from both the vestibule, from the labyrinth and from the proprioceptive, so that both these signals reach the brain, so that brain can interpret what's happening, what position is supposed to maintain, and which muscles are what kind of signals to send to which place. So now the signals suppose if they occur simultaneously, both from the labyrinth and from the proprioceptive, if they occur simultaneously and if they occur sequentially, what will happen? So if it occurs sequentially and these signals are processed sequentially in the brain, it gives one advantage, is that in case one signal is lost, suppose vestibular loss, so the brain, since it's processed, the signal arrives sequentially and it's processed sequentially, so the brain can use the more of the proprioceptive information and then try to maintain the balance, but rather than when the signal occurs sequentially. So let's assume that happens, and let's see what happens in actuality with the timing of these signals coming from both the vestibule and the proprioception in regards to these movement, that is the pitch and the roll. So what happens that when your body pitches, these are through various experiments which have been done. So when the body pitches, when your body is pitched, so like your leg is perturbed backward, the body tends, now what happens, first of all, the first movement which occurs is your head, your neck movement, that is set into a linear acceleration. linear acceleration within with a delay of about 10 milliseconds. And after that, what happens that the trunk sends the proprioceptive information a little later than the information coming from the neck. So because this happened because the trunk is pitched about 50 milliseconds after the pitching of the head. So this is pitched later. So what happens that so this shows that the signals from both they reach the center of control in a sequential manner, and they are therefore processed also sequentially. Now, what is the advantage of having the sequential processing and the signal reaching sequentially is that the advantage is in vestibular loss is that an individual will use a third information. Okay, suppose vestibular loss, so it will now not only depend on the proprioceptive information, it will get another information to maintain the balance, that is from the what is called the load receptors. Now the load receptors are there in the spinal column. So and they register the upward and downward thrust of the surface. So now in vestibular loss, they will also utilize the proprioceptive coming from the ankle and then also from the load receptors. So now we will see what the difference is with a roll. Now when your body is sent into roll, now it is seen that these signals coming from the proprioception and the vestibule, they occur almost similarly, parallelly. So when they occur parallelly, there's no difference in that signal from these both from the proprioception and the vestibule. The difference is very short. So it does not allow this the third signals to come into play to help each other in the loss of one of these signals. So what is the effect on stance and gait? And these are these now we are coming to more clinical applications. When you have a bilateral vestibular loss, in a bilateral vestibular loss, you ask a person to stand, he can almost maintain his balance even while standing, or else even while eyes closing, when he puts in a lot of concentration, he can still manage it to stand upright without falling. Now how will you try to disrupt this? You can disrupt this balance and check suppose in a bilateral vestibular loss by asking the person to stand in a foam support. So in the foam support, what will happen is that this person now who has been able to stand erect while on a firm solid and a firm base, now when he stands on a foamy balance, he'll tend to fall. Now why is this? This is because that the person with bilateral vestibular loss will depend a lot on the ankle proprioceptors. But the ankle proprioceptors are not very effective in giving the information of the body tilt when he's standing on a foamy support. Okay, so testing a person on a firm solid stance on a surface and on a foamy support, this is a very sensitive test to detect the bilateral vestibular loss. But remember that it is not specific again, because you can have it in you can get these problem when you're dealing with a patient with diabetic neuropathy, or in patient with spinal cerebellar ataxia. So you can have these problems. Now by doing this we can differentiate between vestibular loss and proprioceptive loss, because as I told you, vestibular loss, they will depend on the ankle proprioceptive informations also. So because now when you ask the person to stand on a foamy support, the ankle proprioceptors are weak, they're not effective, so that is unreliable, the visual is cut off, so they will not be able to maintain balance. But if the person has a proprioceptive loss, the person will stand on a solid firm base and he closes his eyes, he will still not be able to maintain balance, because the proprioception from the lower limb, they are poor. Now, but how do you identify the proprioceptive loss? That is by a simple test you do, which is very cheap and easily available is by doing the, I'll just show you a video here, by doing a tuning fork test. So just this video is just show you how to exactly do, how to elicit these tests in a correct manner. So generally you can use a 128 Hertz tuning fork. This is a video downloaded from YouTube. But I'll just show you only the important part.
And then place it at the bone. What we'll then do is...
So what you do is, you set the tuning fork to vibration, and you put the vibration at the toe, and ask the person whether they can sense vibration or not. Okay, and if he senses vibration, after that what you can do is, you can stop the vibration of the tuning fork and ask the person whether he can still feel the vibration or not. You can do this with eyes closed, so you become more sensitive. So if say if you're doing the test in the proprioceptive, the vibration test in the toe, and you find that it's absent, you can go ahead and on the dorsum of the foot, on the ankle, you can go on the shin, you can go up to the patella. So this you can do these vibration tests and try to find the level at which these vibration senses are lost. But at the same time, is it sufficient just to see that proprioception by doing this vibration test, or whether because you need also, because of proprioception, whether is it proprioception loss or whether some problem with the joints. So we need to we need to do a small test again, which is an additional test, that is to do the test of the joint position. This is a very easy test, because this will give you it will tell you the status of the joints. And how do you do the joint test? It's again a very simple test to do. So this test is like you hold the toe with your fingers, avoiding to touch the other toes, and then you can ask the person to close his eyes and then move the toes up and down, and ask the person to try to recognize in which direction the toe is moving. So that way you can assess the status of the vestibule and differentiate it from the proprioceptive loss, and then again you should always check for the joint position. Since as I have told you before, that there's a lot of problem with the in the balancing role compared to pitch. Okay, so what happens that when you see a person with when you check a person with instability during tasks, then you see them when you ask them to walk. So just walks 3 meters front or back with eyes closed. You will see that they have a problem with the pitch. So if they compare with the normal subject, they will these patients will tend to pitch forward. These are simple tasks, so they tend to have more pitching. So because you're not involving this kind of movement, since just this movement, so the patient tend to maintain the balance by trying to by increasing the pitching movement more. But now, when you ask them to do a more complex task, like make him sit, get up and walk, there it involves the movement of the roll movement. It is in these patients, they really tend to fall, and when you ask them to do a complex gait, they will always tend to have more of these roll and more of falls. Now when to test them? It is suggested that in a vestibular loss, you test them at the onset and then again at 3 weeks. Why at 3 weeks? At 3 weeks, because by then spontaneous nystagmus has settled, patient has recovered. By 3 weeks, generally they recover from the normal control of stance. And third is that the neurochemical changes which are involved with compensation, they are complete by 3 weeks, and again you test them at 3 months. You test them 3 months. The reason is that the VOR response for low acceleration, so they have gained symmetry by then. But you see that when you test them at 3 months, these for simple gait, as I told you, walking forward and backward, they have maintained a balance. Okay, so they generally recover. But for complex gait, they don't recover by 3 months. It takes much longer time. because there it involves a more complex movement where they have more of roll movement, and they have to coordinate with the ocular reflex. So coming to a conclusion, we have to differentiate first between the first of all, we see very few patients with bilateral vestibular loss and more of unilateral, and even if they have a bilateral vestibular loss, first they would always develop a unilateral and then go on to have bilateral loss. Okay, then we have to differentiate between the vestibular loss from the proprioceptive loss. That is by doing these 3 tests, testing asking the person to stand on a firm base and on a foamy base, on a foam support, and then you test the vibration sensors and you test the joint position. And as I told you, because it's related to these movement, the timing, sensory timing, and the way the motor responds, so that you have more imbalance in when it involves a roll movement than when you compare with a pitching perturbation. Okay. And as I told you initially, that because of the difference in the pathway, the difference in from the origin of these the nuclear origin, because they are different from that of the vestibular ocular tract, so their recovery, the compensation is different, and therefore you cannot judge the person suffering from vestibular spinal tract deficiencies. You cannot judge their recovery from the amplitude of these vestibular ocular reflexes. Therefore, just by testing, because of this easy compensation, okay, so at stance especially, so when you're testing for recovery, it is not a wise thing to test only on stance. Just saying, but okay, patient is stance, so he's recovered from whatever deficit he is. So it's always better to test both at stance and performing both the simple and the complex gait. So I've covered the simple gait and the complex gait too. So with that, I would end my presentation. Thank you. Yes, sir.
So in proprioceptive loss,
because of the sensory things, because of the timing on the sensory inputs, because as I told that when you are set into pitch, the timing and sensory from the vestibule and the labyrinth, they occur sequentially. So what happens when you have one particular loss, replacement of that loss by the second input is much better than in a roll. See what happens in a pitch. In a pitch is that from the vestibule, the inputs occurs first, and then from the proprioception arrives a little bit later. So what happens? It gets an additional input coming from the load receptors in the spine. So it can be replaced rather than.
So you say that it is basically because it is coming from cervical proprioceptors, so that is compensated earlier than that coming from the ankle proprioceptors. What you are trying?
No. What I'm telling is, in a pitch position, when you're pitching, the signals, okay, the signal arrive in the center sequentially. It arrives first. So you have a more duration of time for the brain to detect from the load receptors. So it gets an additional input. So that's why they recover, and the imbalance is lesser as you compared in a roll. In a roll, both these inputs from the vestibule and from the proprioception, they occur almost parallelly. So at the same time, so the brain does not get, it does not get an excess input from the load receptors in the spine. So that's why they have a little bit more imbalance in a roll rather than in pitch.